Good afternoon, everybody, and welcome to this session on confronting the challenge of diabetic macular edema. Without much ado, let us start off by addressing the basics of diabetic macular edema, the pathophysiology of DME, which will be presented by Dr. Deepak Arthur.
Good morning, everyone. Good afternoon, actually. I thank the organizers for giving me this opportunity to present here. I'm Deepak Arthur, and I'm from the Institute of Ophthalmology, Joseph Eye Hospital. I will be talking about the pathophysiology of diabetic macular edema to start off this session. So to define it, it is fluid accumulation in the retinal layers, and it is one of the commonest causes of blindness, especially in the developed world, though in our country, cataract and refractive errors still take the lead. So understanding the pathophysiology is of utmost importance when we are trying to treat it. And in this presentation, we'll be looking at the basic pathways which are disturbed, the key factors which are involved, and the various avenues that are available for treatment. So this flowchart actually summarizes the entire presentation of mine. So let us actually go in the reverse direction. First, we have diabetic macular edema, which is fluid collection. So where does this fluid come from? So the fluid is leaking from somewhere, and the only way fluid can come into the eye is through the blood vessels. So something happens, and this fluid is coming into the extravascular compartment. So that is because of the disruption of the blood-retinal barrier. There is generally a barrier which prevents this fluid aggression, but that is broken. And why does that happen? That is because of different biochemical alterations due to hyperglycemia. So as we all know, there is an inner and an outer blood-retinal barrier, the outer being formed by the retinal pigment epithelium and the inner being formed by the tight junctions of the blood vessels. So there are these multiple molecules which act as tight junctions. I'm really not going into the details, but there are these molecular level stuff which prevent blood from coming into the retina, both from the outer and the inner levels. So what happens? What are the different biochemical changes that happen? The ultimate factor, the culprit here is hyperglycemia. We have increased sugar levels. So because of these, several cycles get activated. These are cycles which do not normally happen in extensive levels in a normal physiological state. But when there is hyperglycemia, these pathways get activated, like the polyol pathway, which leads to sorbitol accumulation, and NADPH gets depleted, which is a very good antioxidant. Then we have the protein kinase C, which again gets activated, which in turn leads to VEGF signaling. And then we have these advanced glycation end products. Still we have excess sugar, so they need to be metabolized in some way. So they get attached to proteins and different things happen, and they give rise to these advanced glycation end products. Again, they lead to structural changes. So basically we need to know that these abnormal cycles get activated when there is hyperglycemia. So now we have these abnormal cycles running. So what happens next? These cycles give out these pro-angiogenic factors. So these are chemicals. These are bad chemicals. Actually not bad, but in this scenario, they act in a bad way. They give rise to all the consequences. The lead one being vascular endothelial growth factor, are the famous VEGF. Along with that, we have platelet-derived growth factors, angiopoietin, osteopoietin, erythropoietin, and all of these are growth factors which are actually needed for physiological processes. But in this scenario, they act on the contrary. So the lead one being VEGF, VEGF-A especially, and again placental growth factor. So all these are the key drivers in the angiogenic drive, which increases the vascular permeability. And they ultimately lead to a breakdown of the blood-retinal barrier. And also in the pathogenesis of proliferative retinopathy, they also lead to new vessel formation. So that in turn also exacerbates DME. But not alone these angiogenic factors. There is a separate component of inflammatory changes which happen. Just like how those angiogenic chemicals came into play, we have a separate set of inflammatory cytokines like the interleukins, tumor necrosis factor, matrix metalloproteinases, and all these chemicals also come into play, and they amplify the inflammatory reactions which are already going on, and they again contribute to the breakdown of blood-retinal barrier. So now we saw these bad chemicals, which are the angiogenic factors and the pro-inflammatory factors. But we also have some good chemicals. These are chemicals which prevent these macular edema formation. What happens in hyperglycemia? All these good factors get downregulated, like the brain-developed neurotrophic factor, the pigment epithelium-derived factor, the ciliary neurotrophic. All these are good factors, but they get downregulated. And this is another structural change. So these were all the biochemical changes. So what happens in the structural changes? So there are different mechanical forces which come into play. Initially, I had spoken about these advanced glycation end products. These are again some things which are derived from this excess sugar which is present. So they start getting attached themselves to the different protein molecules, leading to formation of this cross-linked collagen. So all the collagen layers, all the membranes in the retina and in the vitreoretinal interface get disturbed. So once a vicious cycle starts, there's something called a positive feedback mechanism. So once a bad thing happens, once there is chronic hyperglycemia, there's inflammation, there's angiogenesis, and it just eventually perpetuates itself going on to a vicious cycle. So what are the different anatomical changes that happen? We saw that VEGF increases in concentration. VEGF increases in concentration both as an effect of hyperglycemia and also because of hypoxia per se. So because of both these cases, VEGF goes up. And there are all these anatomical changes which we would have all studied, like the loss of endothelial cells, pericytes, basal membrane thickening, and all these things happen. And ultimately, there results and blockage in the retinal blood flow. And all these cytokines and chemicals which I had spoken about come into this loop, this vicious cycle, ultimately leading to disruption of the blood-retinal barrier. So if we actually go into the cellular level, they say that the Muller cells are those glial cells. They are the cells which are first affected. They swell up, and eventually the bipolar cells, ganglion cells, and photoreceptors all undergo different structural changes like elongation. So, and when it is in an intracellular level, it is very reversible, and just normaling the sugar levels gives a normation of the values. But once the next stage is when the fluid passes on to the interstitial spaces, that is between the cells, the fluid starts accumulating in the spaces, all those cystoid spaces start forming, and that goes to a level of irreversible damage. And that is when all our treatments and anti-VEGF agents come into play. And again, as we know, lipid deposition because of all this leads to hard exudate formation, and a disruption in the retinal pigment epithelium also gives rise to subretinal fluid. So these are the different anatomical changes that can see. So summarizing it, there's hyperglycemia, there are all these bad chemicals that come up, they induce angiogenesis, they induce inflammation, and ultimately all these chemicals together play a role in the blood-retinal barrier disruption, leading to diabetic macular edema. So to conclude, the pathophysiology of DME is a complicated one. So we have biochemical, angiogenic agents, inflammatory processes, and mechanical forces. So we need to know, have a basic idea of all these things so that early intervention and targeted therapies at each of these levels, which could help us in successful management of diabetic macular edema. Thank you.
Thank you, Dr. Deepak, for a very concise presentation of the pathophysiology of DME. From understanding the pathophysiology, let us look at how we can approach the management with an overview of anti-VEGF agents in diabetic macular edema by Dr. Syed Moeddin.
Good afternoon. I thank TNR for giving me this opportunity. So, yeah. For years together, lasers were considered as the gold standard for treating DME. The ETDRS has clearly shown that lasers reduce the diabetic macular edema, but it does not cause the improvement in vision. So the search for the other modalities kept continuing, and the introduction of anti-VEGF agents has caused a paradigm shift towards the management of diabetic macular edema. So under the umbrella of anti-VEGF, we have a lot of molecules, that is aptamers or antibodies to VEGF or antibody fragments or fusion proteins and single chain fragments. Though the aptamer, that is pacaptanib, was the first anti-VEGF molecule to be introduced, it was effective against only one isoform of VEGF-A. And the other molecules were more superior, so it went off the market. So bevacizumab, the poor man's savior, was a full-length humanist monoclonal antibody which inhibits all VEGF isoforms, and it has a half-life of about 7 days. And though, like off-label, multiple studies have proven that bevacizumab was effective in reducing the macular edema. It was found that almost it causes 40% or improvement in vision, and also causes a very well reduction of macular edema compared to the laser monotherapy. The legitimate drug ranibizumab is also it also blocks all the isoforms of VEGF-A. It's a recombinant humanist FAB fragment having a low molecular weight, and it has a higher affinity than bevacizumab. And the RESTORE study has clearly shown that it is the ranibizumab monotherapy was superior to laser in reducing the macular edema. Similarly, the RISE and RIDE study, which compared with sham injection, also clearly shown that ranibizumab was better than sham injection in reducing the macular edema and causing visual improvement. And besides this, other studies also clearly shown that intravitreal ranibizumab monotherapy was superior to laser monotherapy, and additional laser, either prompt or deferred, was not necessary to increase the vision in diabetic macular edema. The other drug, aflibercept, which is a chimeric fusion protein, which contains receptor 1 and 2 VEGF fusion with a human FC domain of the human immunoglobulin G1. It has a greater affinity to VEGF-A compared to the other two molecules, and besides that, it also inhibits the VEGF-B and placental growth factor. and it's having a longer half-life also. The VISTA and VIVID studies clearly shown that it has aflibercept is better in reducing the macular edema, and it also clearly shown that the dosage, that is, the dosage can be given at 4 weeks or even 8 weeks dosage regimen also has a equally effective results in causing reduction of macular edema and improvement of vision. And the DRCR net protocol net compared all the three drugs like aflibercept, bevacizumab, and ranibizumab. And what they have inferred is vision gain is present in all the three group of drugs. And the number of injections required to reduce the macular edema was reduced in the subsequent years, and decreased frequency of visits and decreased amount of laser photocoagulation is needed in the subsequent year. Another important observation is if the patient is having a better vision, then there is no difference in efficacy of all the three drugs. Whereas if the patient is having a little bit poor vision, aflibercept has an edge over the other two drug molecule. And the extended results of protocol T also clearly showed that the treatment with anti-VEGF has a better result compared to the like a natural course or laser monotherapy. And we have now a lot of molecules which are similar to the patent molecule, like there is not biosimilars. And the RENACT studies has clearly shown that ranibizumab biosimilar has a equally effective effect compared to the original molecule. And now the recent kid on the drug is brolucizumab, which is a humanized single chain antibody fragment, which is a smaller in size, which is having a 26 kilodalton molecular weight. So it has a more concentration of drugs can be delivered in a single dose, and the effective tissue penetration and increased duration of action has been reported with this drug. The recently published Kite and Kestrel trial has clearly shown that brolucizumab have a almost equal good effect with aflibercept, and the duration of the interval of drug injection, that is very important. It can be given at the interval of 6 weeks, or maximally it can interval of about 12 weeks can be adjusted. And other molecule like faricimab, which is a bispecific antibody which inhibits both VEGF-A and angiopoietin 2 also. And the importance of this drug is the injections can be given at 16 weeks intervals. They recently concluded the Yosemite and Ryan study has clearly shown that the interval can be adjusted up to 16 weeks. So the current indication of anti-VEGFs in diabetic macular edema is the serial injection of anti-VEGF is the first line of therapy in center involving diabetic macular edema, because not only it causes reduction of macular edema, it also causes reversal of visual impairment and improvement of retinopathy severity, and also the slowing the rate of progression of retinopathy. And it's found that the frequency of injection needed is decreased in course of time. The DRCR protocol has been clearly shown that monthly injection of anti-VEGF should be considered for at least 4 to 6 months initially, and the treatment can be withheld if there is no improvement in vision or central subfield thickness, or if vision is improved to 6/6 or the resolution of DME has been achieved. Then the patient can be periodically followed up, and it can be resumed if the worsening of vision or central subfield thickness is found out, or if on consecutive visits the treatment is not required, the follow-up can be extended beyond up to 4 months. And another alternative approach is to do a treat and extend regime, where the interval between the visits and injection can also be extended gradually depending upon the response. So when to stop anti-VEGF? If there is a no further improvement, that is, if there is less than 10% decrease in central subfield thickness, or if there is less than 1% line improvement in visual acuity, and also based on the opinion of the treating ophthalmologist. In eyes which have a better vision, then we can observe, that is 6/6 or 7.5, you can, with persistent DME, one can observe without giving injection, and if the vision drops or subfield thickness increases, then one can re-inject the drug. In case of recurrent DME, one can use the same anti-VEGF to treat the recurrences. And in case of non-responders, that is the most common reason for inadequate treatment. The most common reason for non-responders is inadequate treatment. And in eyes with persistent DME and vision less than 6/12, then one can switch over to another anti-VEGF, or you can consider steroids also. Safety, it is almost safe except any recent major cardiovascular event, a stroke or cardiac arrest or uncontrolled hypertension, you should be very careful. And pregnancy, it should not give. And if there is a TRE threatening the macula, in case of pedia, then also you should be very cautious in giving anti-VEGF. And in presence of inflammation also, you should avoid giving anti-VEGF. The most common dreaded side effect is injection, like endophthalmitis. So adherence to proper antiseptic agent is very important. Besides, you can get a lot of things like hemorrhages, vitreous hemorrhage, IOP rise is also reported with the anti-VEGF agent. So the limitation of anti-VEGF is the frequent injection is a relatively burden to the patient. It causes stress and financial burden. And because of that, most of the patient will not adhere to the treatment schedule. And this causes under-treatment and incomplete treatment in the real world. And there is also increased risk of infection and endophthalmitis and ocular hypertension already in relation to the anti-VEGF. So another subpopulation patient, because most of the results have shown that 30 to 40% are responding. So subpopulation patient do not respond to anti-VEGF. So we can try about the other treatment, which our subsequent speaker will highlight. So to conclude, serial injection of anti-VEGF is now the current standard of care for central involving DME, and anti-VEGF therapy reverses the visual impairment. So newer drugs has come into the market, so we can give the drugs at a longer interval, and still bevacizumab is the cost-effective treatment in treating the diabetic macular edema. Thank you. Yeah.
Thank you, Dr. Syed, for summarizing the vast amount of information on anti-VEGF so succinctly in the short time. Next, we have Dr. Saban Horo, who's going to come back, and after the anti-VEGF, he's going to show us how lasers still have a very valid role in the management of DME.
Good afternoon, everyone. At the outset, I'd like to thank the TNOA organizers to have my talk here, and the panelists and all the delegates sitting here. I'll be talking on laser therapy. I have no financial disclosures to make. These are my outline on which I'll be talking. And as I said, as Deepak had already talked about the pathophysiogenesis of the diabetic macular edema, it is one of the most common cause of visual impairment. And retinal vascular hyperpermeability causes edema with fluid accumulation in the outer plexiform and inner layers of the retina. So there is a breakdown in the blood-retinal barrier which causes macular edema, and the main mechanism is opening of the tight junctions between the endothelial cells. So the prevalence of diabetic retinopathy in India ranges from 17.6 to 28.2%, out of which 10% of the people with diabetes suffer from sight-threatening diabetic retinopathy. That includes diabetic macular edema. And the incidence of DME in India ranges between 6.3 to 8.9%, according to various studies that have done. So ETDRS classified diabetic macular edema as clinically significant macular edema way back in 1985, and this is how we all know. Then came the International Clinical Diabetic Macular Edema Disease Severity Scale, which based the diabetic macular edema present or absent, and if it is present, it is divided into mild, moderate, and severe. Then came the OCT-based classification by characterizing the various layers and various morphology of the retina into retinal thickness, retinal topography, macular traction, foveal photoreceptor status. Now what we follow right now is the ICO guidelines for diabetic macular edema is the most commonly followed, where center involving diabetic macular edema is thickening involving the central subfield zone of 1 millimeter in diameter, and non-center involved diabetic macular edema. Diagnosis of diabetic macular edema can be made on clinical examination with fundoscopy, color fundus photography, OCT, and also FFA. So laser therapy works by means of occlusion of leaking microaneurysms, RP stimulation, inducing endothelial division, reducing oxygen consumption, and increasing choroidal oxygen diffusion. So what did ETDRS say? That macular laser therapy was the mainstay of treatment for over 3 decades, and it demonstrated that focal and grid laser reduced the risk of moderate visual loss by 50% at 3 years. However, that 3% of patients only improved by 15 letters or more. DRCR protocol T compared the 3 anti-VEGF agents, aflibercept, ranibizumab, and bevacizumab. It showed that 36 to 39% of the subjects in each treatment group had focal or grid laser before the injections, whereas in 37 to 56% of subjects had focal or grid laser during the first year of the study itself. However, the effect of laser was not studied, but the eyes receiving laser was quite significant in all the groups. So DRCR network and clinical trials show that the outcomes with laser have improved significantly. with improvement with glycemic control, BP control, and also improvement in the laser technologies. DRCR Protocol V studied the center involving diabetic macular edema in eyes with excellent vision. And it compared the 3 treatment arms, prompt anti-VEGF, that is aflibercept, baseline focal and grid laser, and observation. At 2 years, the visual acuity loss of 5 or more letters did not differ significantly, and the average visual acuity was 20/20 in all the groups. 3/4 of the eyes in laser group and 2/3 of the eyes in the observation group did not receive any anti-VEGF. So micropulse laser, which has been there, but we have not much people going in for it, but recently there are a lot of publications and studies being done with 577 nanometer and 810 nanometer wavelengths. It produces an effect without causing any visible intraretinal damage. Low energy decreases the risk of hemorrhage, temperature buildup, and thermal damage. So micropulse has been shown to be effective as argon laser in multiple studies. It results in better preservation of retinal function on electrophysiological studies. And also, micropulse, when given in a high-density mode, is more effective as compared with modified ETDRS, focal or grid laser, or normal density micropulse treatment. The study showed that 1 year time, the high-density subthreshold diode micropulse laser had best improvement in vision, 0.25 logMAR versus other groups. But all the groups had significant reduction in the central macular thickness, with the highest of in the high density micropulse laser of 154 microns. You can also do a transfoveal micropulse laser, and it has been shown to be effective and safe in treating center involving diabetic macular edema in eyes with good vision. A study comparing micropulse laser and PRN ranibizumab to ranibizumab monotherapy for diabetic macular edema concluded that laser significantly reduced the injection burden at 1 year of 1.7 versus 5.6. We have something called navigated laser system, which has very limited centers or places doing that, and where there is a retinal eye tracking, which aligns the laser treatment to pre-planned treatment map. It allows accurate laser treatment to the microaneurysms. One of the studies showed that eye tracking ability of the Nevilas was 20% more accurate than the slit lamp based laser. So now coming to the case scenarios, this is a 75-year-old man, diabetic on OHS with uncontrolled sugars, had decreased vision for 6 months. BCVA right eye and was 618 and 18, left eye 636 and 36. Anterior segment was a mild immature cataracts. Fundus showed severe NPDR. And OCT showed a mild intraretinal fluid in the right eye and ERM with loss of foveal pit in the left. He underwent manual small incision cataract surgery after control of sugars, and 1 week and 1 month post-op vision was 6, 9, and 6. But the OCT shows intraretinal fluid which was involving the center, and macular grid was given. And macular LS eye drop started for a month. So 2 months post-op, his vision dropped to 6, 12, and 8, and OCT showed an increase in intraretinal fluid, which involved the center again. So injection Avastin was given 3 months after the cataract surgery, and the vision recovered to 6, 9, and 6, 1 month later of Avastin. Case 2, where a 74-year-old lady, diabetic and hypertensive, right eye, complained of decreased vision, BCVA 6, 18, and 18, both eye immature cataract and fundus. And for this, focal laser was done, and the vision was 6, 9, and 8. Case 3, again, immature cataract, severe NPDR, with OCT showing a center involving macular edema, and 3 doses of Avastin was given, where it had come down but not significantly, and we had given the option of Ozurdex and Eylea, but the patient refused, so we gave posterior subtenance TCA. But still, she has a macular edema, but she maintains a vision of 6, 18, and 18 in both the eyes. So what is the role of laser today? It has shifted from first line of treatment to stabilize visual and anatomical improvements after initial anti-VEGFs, to decrease the injection burden, and also READ2 study implied that the combination therapy with laser may decrease the residual edema and injection burden. Deferred focal laser is better targeted to microaneurysms with micropulse laser or further decreased vision. Subthreshold laser holds promise, and anti-VEGF treatments within 6 months after the cardiothrombotic events, where the laser has a major role to play. In conclusion, it is cost-effective with anti-VEGF injections, reduces treatment burden. It is safe in patients with recent MI, stroke, and cardiac heart failures. Absence of collateral thermal retinal damage with micropulse lasers, accuracy of navigated lasers. Focal diabetic macular edema responds better to focal laser than the diffuse macular edema. Thank you.
Thank you for an excellent disclosure on laser therapy. Audience, we will address all your queries and questions by the panel at the end of all the talks. We next have Dr. Rajiv Raman, who will be enlightening us on the use of steroid therapy in the management of diabetic macular edema.
Good afternoon. I would like to thank TNOA for giving me this opportunity to talk about steroid therapy in diabetic macular edema. So I'll cover these points. We'll see why steroids in DME, when we can consider giving steroid, when not to give steroids, and which steroids, and how to give these steroid injections. So we had heard before a pathophysiology talk, and I was just looking at since when we think about diabetic retinopathy as inflammatory disease. It was way back. Even if you look at Duke Elder, he starts it with it's an inflammatory disease. So long back, it is known that it is inflammatory disease. Very beautifully, he talks about in 1960s. He tells that it's one of the major tragedies of ophthalmology in our generation. It's common, rapidly, still more common, affecting young and aged. So there are a couple of good points which Duke Elder talks about diabetic macular edema and diabetic retinopathy. And it's not only diabetic retinopathy, many other vascular conditions, even inflammatory like uveitis, wet AMD, vein occlusion, diabetic macular edema, all of them, there are inflammatory mechanisms which play a role. It's not only diabetic macular edema. And what regulates these genes? This is one of the work by our genetics department. So there are some miRNAs which are very much particularly involved in inflammatory pathways. And it's not only in diabetic retinopathy, you can see even in AMD, couple of these pathways are activated. So inflammation does play a role. And there are enough studies which have shown, this is work by Lee et al., who tried looking at aqueous cytokines. Though we see that VEGF definitely increases, but you can also see that many of these inflammatory cytokines tend to increase in aqueous. And this is one of the work which we had done in vitreous. Also, you can see a lot of these inflammatory cytokines are raised. So definitely in diabetic macular edema, inflammation seems to play a role. And whenever you have inflammation, the only drug you think of is a steroid. So steroid does play an important role. When can we consider giving steroids? So one is definitely, as previous speakers have told, that it is not responding to anti-VEGF. Again, what should be the threshold? Even after first injection, if you see that edema is increasing, or first of 1 or 2 injection, there is no harm thinking about that whether we should switch. It is responding. Some cases we see that they respond pretty well, but they are very reluctant coming on a frequent visit, and they come after 4 months, edema is again the same as it was at the first visit. These are again the cases where you can think of giving steroids. If a person with macular edema undergoing treatment and he needs a cataract surgery and there is still a persistent edema, definitely steroid is something you can think. And in pseudophakic patients who have plateaued, though many of us also use it as a first line agent, but anti-VEGFs, if you are started on a pseudophakic patient and at some time you feel that it's not improving, there are IRF, that's a case again steroids play an important role. If there is a history of vascular event, it can be cerebrovascular or a cardiovascular event within last 6 months, or if there is occurrence of systemic vascular event while the patient is on anti-VEGF, again that's an indication you should avoid giving anti-VEGF. Steroid plays a role. Associated features like extensive hard exudates, the plaque of hard exudates, if they are there, they though it's not like anti-VEGFs don't work, but they need much more number of injections as compared to steroids. We should be cautious that even if the edema reduces, the visual improvement may not be great because these hard exudate plaques tend to have a RP atrophy. As far as OCT features of inflammation, I'm not going into detail, but there are certain, next talk we'll talk about it. They are the ones where you can think whenever you are switching. So it's not like your OCT markers will tell you you have OCT markers, give steroid, not anti-VEGF, but it's not the case. But if a person is on anti-VEGF and is not responding, and you see these OCT markers of inflammation, you're switching, you can think towards steroid. Regarding pregnancy, if it's the last trimester, don't treat because after delivery, many a times the edema may come down. First trimester, second trimester, you can think of injecting steroid. You don't want to give anti-VEGF. Again, first trimester is a bit query. There are reports talking about cleft lips, even with the intravitreal. So you can think of laser in the first trimester, second trimester, think of steroid. Post vitrectomy, again, because the vitreous sump is not there, and these are the cases where you steroid giving inside, it remains for a little longer time. The anti-VEGF washout would be more quicker. You'll need more number of injections. So these cases, steroids have a role. However, again, a word of cautious because these are vitrectomized eye. When you're injecting these steroids, especially the Ozurdex implants, have a more intrascleral route because you must understand it's a 22 gauge needle, and you will sometimes, I have seen a couple of patients having hypotony, one even having choroidal detachment after this. So that's something you should keep in mind. When not to give steroid, when you should definitely try to avoid is definitely if a person is having glaucoma. However, if you are very much keen and he's not responding to anything, with your glaucoma colleague, looking at how many drugs he is on and how much is the damage to the optic nerve, you can take a call. Just 2 minutes. In aphakic eyes, in SFIUL, you want to avoid giving steroid. Young patient, we do see many times now young people with diabetes having macular edema, clear lens you try to avoid. And this is one of them which I had, though it's a local immunosuppression, if I had prior herpetic infection, there can be reactivation. So don't only look into the eye, but the surrounding face too. What evidence say? Definitely, we have variety of steroids. We have triamcinolone 1 milligram, which we today give, or a Dex implant. We don't have, but fluocinolone implants are also there. The duration of effect seems to be highest with fluocinolone. The risk of complication also seems to be more. A proper mix probably would be the Dex implant, which has got both a reasonable duration and less complications. Again, these are some pictures of steroid in the wrong place. You have the pseudohypopion, you have Ozurdex implant in the front, Ozurdex in the lens. Try to give it properly. There are a lot of evidence. I'm not going in detail, but there are evidences for triamcinolone, for Ozurdex, and for the fluocinolone. It does show that it reduces macular edema. All these studies show that anatomical results are definitely much better. Functional results are not that great as compared to anti-VEGFs. There are evidences regarding combinations, but we definitely need more evidence regarding it. This is a small video which shows that how to give this injection. So do a routine painting, draping. It's important. As I told you, it's a 22 gauge needle, and mark your pars plana, and then this is the guard which you remove. There is an intrascleral path, and then you go vertically down towards the optic nerve head and inject the drug. Lastly, again, don't forget to put a povidone iodine and patch. Thank you very much. Any questions, I'll be happy to take.
Thank you, Dr. Rajiv Raman. We'll take questions at the end of the session. To go further on our journey towards finding the best management for the patients with diabetic macular edema, we now have Dr. Naresh Babu throwing some light on the surgical management and in which cases one would think of intervening surgically in a case of DME.
I think 12:30. Good afternoon all, and thank you, chairpersons and the moderator. And I don't have any financial interest in this. And before going, I would like to thank my colleagues, Dr. Muthukrishnan, Avik, and Ananya for helping me in making this presentation. So a lot has been spoken about this diabetic macular edema. So we have to identify whether it's tractional or non-tractional, because most of these diabetic edema will be non-tractional and can be treated with anti-VEGF or steroid. So as a VR surgeon, only a fraction of these cases come to us actually, because all the things have been tested before it is being managed by us. So we all know that based on the OCT, we have got some 5 types of macular edema, and many of these can be treated very well with anti-VEGF or steroids or with the lasers. And in the last 2 category are the one which will not be responding, and it is very easy to identify with the help of OCT so that we can intervene early in these cases. But sometimes after even multiple injections, if they are recalcitrant, then also we can take them for VR surgery in these cases. So these are the things, the last 2, the traction and the posterior highlight, which usually comes to us for the surgical management. So what happens in case of macular edema when you do the vitrectomy? Usually in case of non-tractional diabetic macular edema, which is recalcitrant, you can go for the pars plana vitrectomy. Along with that, you can inject dexamethasone implant inside the eye, which will be staying inside the eye for a longer time and sustained release. And that leads to reduction in the macular thickness, as well as there is an improvement in the, the vision also. But in case of diabetic macular edema due to traction, when you do a vitrectomy, we usually do the ERM peeling as well as the ILM peeling, and that leads to the improvement both in the thickness as well as the visual acuity. But whereas in the previous one, the visual improvement is not that significant because everything has been tried. So basically, the incidence of spontaneous PVD is much lower in diabetic when compared to the people who are with DME. So when there is the vitreous causing traction over the macula, better not to wait actually. It's not going to have any PVD and it's not going to resolve the macular edema so spontaneously. So it's better that we go for the surgery earlier in these cases. See, in one of the studies by the Hikachi, it has been noted that when you do a PVD induction, there is a spontaneous resolution of macular edema in almost 55% of the diabetic patients. And usually in case of diabetic vitreomacular traction, we have a lot of spectrum actually. The spectrum includes fibrovascular proliferation without tracheal retinal detachment. We can have a tracheal retinal detachment, and we can have even macular hypertrophy. Heterotrophia. The basic problem with this is even if we operate, most of the time they will not improve beyond 6/60, especially in the last category, because the fovea is totally out of its place because of the traction. So whenever we come across traction over the disc, don't wait, go for the surgery immediately. So when you do the vitrectomy, in this case, what happens? You are basically going to remove the posterior vitreous highlight, and thereby you are going to relieve the traction, and that leads to the reduction. In addition to that, what happens? It increases the oxygenation also. In fact, the release of the VEGF is also reduced in these cases, and it can also facilitate the effect of anti-VEGF, even though the half-life is reduced in these cases. But there are certain challenges in these cases. Sometimes inducing a PVD may be difficult, and we have to remove both the ERM and ILM, because in case if you don't remove the ILM, sometimes there is chance of recurrence of ERM in these cases, leading to the worsening of the condition. Yeah. Okay. So, in fact, when we see actually there are a lot of evidences which says that there is a significant improvement in the visual gain, along with the resolution of the macular edema, especially when you do a pars plana vitrectomy with membrane peeling in cases where you have this. So this is a 56-year-old gentleman. Actually, if you see the fundus on the left side, his vision is 6/36, but looks fine. There is nothing grossly, but when you do the OCT, we can see a taut posterior highlight as well as the ERM. So in this case, what we have done is basically we have gone for the vitrectomy in this case. So in fact, it helps. It's a case of PDR, so it helps in even preventing the further progression of proliferative diabetic retinopathy. You can see the macular edema, and there is a thick epiretinal membrane. After doing a complete vitrectomy, in all these cases, I usually use PFCL, because the retina is very, what you call, flappy in these cases. When you peel, actually, there is no support, and it's a bit difficult to peel the membrane. So I usually use PFCL, which acts like a third hand. Under the PFCL, we usually use what you call the BBG dye. So when you inject the BBG dye in the interface, you don't need to wait for a longer time for the staining. And once it is done, you can just peel the ILM. And unlike the macular hole or the, what you call the epiretinal membrane or in other conditions, here the ILM will not be coming in toto because it's so fragile that it comes in bits and pieces. But care should be taken not to touch the retina, and if there is lot of cyst in the fovea, better you can avoid the, what you call, fovea. But otherwise, going across the fovea is not an issue. So you can see the entire, what you call, the ILM is peeled. And once it is done, sometimes we inject Osodex implant also, or just do a fluid air exchange. And if the PDR is there, we'll go for the additional PRP in these cases. And usually we fill these cases with SF6 and close it. So this is the result of this case. He came to us with 6/36. At the end of 1 month, this was 6/18. And it takes a longer time for these cases to resolve. For want of time, I think I'll skip the other videos. So this is one of the cases where you can see the fovea is totally dragged towards the disc, and a lot of this fibrous proliferation. Word of caution, like most of us will be seeing diabetic patients. So I want to tell only one thing. When we come across these cases where the, what you call, the retinopathy is very worse, please ask them a question, because most of these people, apart from allopathy, they will try all the pathies like Pasupathy, Gajapathy, Ambikapathy. So just ask them whether in what pathi they are actually, because so that it is possible for us to show them some empathy actually. Right? So in almost all these cases, they will be stopping their regular medication and going in for some local medication, and that leads to rapid progression of these cases. You can find that there is a tractal retinal detachment in these cases. Once it was relieved, at least some useful vision is gained in these cases. I'll just skip it. So we can, in addition to the vitrectomy, we can inject a long-acting steroid, but don't inject triamcinolone, because that will be smearing the lens as well as spreading all along the retina, leads to very messy things. So best thing is to go in for what you call the Dex implant, which will be like a small thread and will be releasing the dexamethasone in a sustained way and act for a longer time. Okay, I'll just skip. So just to conclude, diabetic macular edema, most of the time it can be treated mostly with anti-VEGF, and if it is non-central involving, we can use lasers also, or we can use steroids or a combination, and especially if you're going for phaco with combination. But a very fraction of these cases which don't respond, which usually needs what you call the surgery, and before that you identify whether it's a tractional macular edema or non-tractional. If it is tractional, always we have to go for surgery, and the taut posterior eyelid patients are the one who will be very nicely benefited by doing a vitrectomy. And the role of vitrectomy is very well established in these cases. So when you come across tractal retinal detachment, the first thing we can go for is direct vitrectomy with or without steroid in these cases. And when you are doing the vitrectomy, PVD induction is mandatory. Peeling the ILM along with the ERM is mandatory, because if you leave the ILM, there is a recurrence of ERM in these cases. And we have to relieve all this AP as well as the anteroposterior as well as the tangential traction, thereby increasing the oxygenation. And when you use the Dex implant along with the, the procedure of vitrectomy intraoperatively, it is quite beneficial. With that, I would like to conclude. Thank you.
Now that we have seen the various modalities in which we can treat DME, let's have a look at how imaging and monitoring of the treatment response can be done, presented by Dr. George Maniat. Audience, I hope you're ready with your questions so that we can have a dynamic discussion following this talk.
Yeah. Yeah, good afternoon, everyone. Thanks for the opportunity. I like to thank Dr. Karthik Kumar for his help for this presentation. So let's look at the imaging and treatment monitoring in diabetic macular edema. So I would start with the treatment monitoring first. We have heard about anti-VEGF and steroid treatment. We know that we have all moved from the monthly regimen to now we have either DRCR protocol or a treat and extend regime. The treat and extend regime still has too many injections, so we prefer this DRCR regime or DRCR protocol, which has loading injections, not just 3 injections, but it's until the macula is dry and to further the vision is maximized or stable. And then we stop the injections and monitor the patients monthly and extend the monitoring to once in 4 months, and only restart the injections in the same fashion as we started first. And if there is on a PRN basis, if there is a recurrence of edema. So in DRCR regime, we do defer the focal laser treatment for the first 6 months. So in this DRCR protocol, if you follow, you've seen that the requirement of anti-VEGF injections significantly comes down in the 2nd and 3rd year. So this is the benefit of following this protocol, though there is an early aggressive or increasing number of injections in the first year of treatment. So coming to the topic per se, we are looking at non-invasive biomarkers to predict the vision in diabetic macular edema. So let's look at some of these parameters of imaging parameters. So these are the OCT biomarkers. We'll start with the central macular thickness, or what we call a central subfield thickness, which is a central 1 millimeter zone of the OCT map of the macula. So it has been shown that the central subfield thickness percentage reduction is predictive of the visual gain after anti-VEGF therapy. That is, CST reduction is predictive of the visual gain. So how far this is true, let's see. When we look at protocol A of DRCR network, it shows that with focal laser treatment, there is at best a moderate correlation between the vision and CST changes with focal laser treatment. And because many thick maculas have good vision and vice versa, so there is a paradoxical visual acuity, so there is not really a good correlation between OCT measurement of the thickness and the visual outcome. Even in protocol T of the DRCR net, it is shown that with anti-VEGF therapy, there is at best a moderate correlation between CST and visual changes in DME. So the central subfield thickness is a good anatomic surrogate for monitoring DME, but it's not a good predictor of vision in DME. So when we look at the OCT subtypes of DME, now the classification is into a diffuse retinal thickening as this, or cystoid edema, or we have a serous macular detachment, or a tractional edema. We see that in many of the studies, cystoid macular edema has worse vision than serous macular detachment and diffuse retinal thickening. But it's not really the cystoid changes. Where and how big is the cysts are important, because large cyst at the outer nuclear cyst, more than 200 microns, associated with worse visual outcome in DME. So it is all about the remaining foveal tissue that determines the visual outcome. So here comes the importance of the bridging retinal tissue. This is the residual neural elements that which transmit the impulses from the photoreceptor to the ganglion cells and in the way of Muller cells and bipolar cells. So bridging retinal process on OCT is a positive imaging biomarker which predicts a good vision if it is present for the DME outcome. And coming to another subtype, the serous macular detachment is said to have good visual outcome with anti-VEGF therapy, but in the presence of hyperreflective dots, it is also said that this is an inflammatory biomarker, so DEX implant may be better in this kind of a OCT subtypes when you see the serous macular detachment. So overall, there is no consistent data to say that which morphological subtype on OCT is predictive of visual outcomes in DME. And coming to another biomarker, that is presence of this less than 30 microns hyperreflective foci, which are the precursors of hard exudates that you see clinically. So these precursor lesions or hyperreflective foci suggest inflammatory response. As already mentioned by Dr. Rajiv, these are activated microglia and is more seen in severe DME, and higher number of hyperreflective foci is predictive of poorer vision in DME, and steroids may be a better option if you see this biomarker on OCT in the presence of hyperreflective foci. Also, the hyperreflective foci in the choroid is also seen, but more in more severe diabetic retinopathy like PDR, and is a poor prognostic marker for vision if you see this choroidal hyperreflective foci in DME. Coming to another biomarker, that is drill or disorganization of the inner retinal layers, as you can see here, within the central 1 millimeter zone. If there is a disruption of the inner retinal layers, as you compare to this side, it is not delineated here. This is called drill. So when you presence of this drill sign shows that centrally located drill more than 50% within the central 1 millimeter zone is associated with poor visual outcome, and for every drill increased by 300 microns, you can expect a vision drop of 1 line after 8 months with this. And the change in drill extent with anti-VEGF therapy is a robust biomarker predicting of visual outcomes in DME management. So visual improvement with drill could be a marker in future therapeutic trials even. Coming to this layer, that is the external limiting membrane, and disruption of the ELM, as you see here, is again a predictive biomarker of poorer vision if you see this in the presence of DME. Also, this layer, that is the ellipsoid zone or ISOS junction disruption, the percentage disruption of ellipsoid zone helps the clinician to more accurately predict the visual outcome in DME when you are treating with anti-VEGF therapy. So the presence or increased percentage of ellipsoid zone disruption associated with poorer outcome. And the grade 1, which is only the ELM disruption which happens prior to the EZ disruption, these grades correlate with the logMAR visual outcome when you treat with DME with anti-VEGF therapy. Also, choroid seems to be thinner in patients with DME. So if you have a patient with greater baseline increased choroidal thickness, it predicts that you have a better visual outcome when you treat with anti-VEGF therapy. Another biomarker is the parallelism, which is nothing but the subfoveal photoreceptors are skeletonized and segmented, which usually will be parallel. And DME, when there is a loss of this parallelism, it is predictive of poorer outcome on DME with anti-VEGF therapy. Lastly, to touch upon one more, this is something called ICHRM, or presence of intracystic hyperreflective material. This suggests chronicity of 6 months or more and is a poorer biomarker which suggests more number of anti-VEGF injections and even steroid implant injections. So it's a negative biomarker for visual outcome. And taut posterior hyaloid phase, already shown by Dr. Naresh, that it is responsible for recalcitrant macular edema and is a negative biomarker. Lastly, the OCT angiography, which is gaining popularity. Without dye, you see this FAZ enlargement first in the deep capillary plexus. So if the patient has still a normal superficial plexus on octa, then you still can expect a good response to anti-VEGF therapy in DME. Also, the retinal vessel density reduced on octa is also a biomarker which can predict poorer visual outcome. And intercapillary spacing is a more sensitive biomarker for early capillary dropout and ischemia. So this octa is important, especially in patients who are pregnant and renal patients where you want to avoid the dye-based angiography. To sum up, we have the negative imaging biomarkers like presence of drill, large outer layer cyst, ellipsoid disruption, hyperreflective foci in the retina and choroid, and taut posterior hyaloid phase, where you expect poorer outcome in DME. And if you see the serous macular detachment subtype on DME, intact ellipsoid zone, better bridging retinal process, and higher subfoveal choroidal thickness, you can expect a better vision when you treat the DME with anti-VEGF. So OCT and octa non-invasive imaging helps in grading the severity, predicting the visual prognosis, and even helps you to modify our treatment regimen in DME. Thank you for your kind attention.
Thank you for the excellent talk. Audience, do we have any questions? If there are no questions, we'll close the session as we are even ending the time. Request the speakers to come forward for a photograph.